Okay, perfect. All right, I think I'm going to stand over here and out of the glare. Hi, everybody. Thank you for your patience. I was telling Emma that what you think is your schedule is really never your schedule. So I meant to dress up for y'all, but that didn't happen. I'm coming straight from clinic. So, but anyway, thank you for the few extra minutes that you guys were waiting. I'm Luisa Solis-Cohen. I'm a movement disorders neurologist. So that means I'm a neurologist, but I have extra training in movement disorders. And the bulk of what I tend to see in the clinic day in and day out is Parkinson's disease. So you may hear a movement disorder specialist and Parkinson's disease specialist as one of a kind. We are definitely the most subspecialized in the Parkinson's disease world. And I practice in Littleton. This is one of my favorite places to go in the mountains. I don't know if anybody recognizes it, but it's Winter Park. And we're going to talk about medicines in Parkinson's today. And in particular, let's see, it doesn't move now. In particular, we're going to talk about how they work. Because every week somebody will ask me, well, I don't know, you just told me about 3 different choices. How am I supposed to help you make that decision? And it's really important to sort of go back to the nuts and bolts of how do these medicines work? What's going on in the disease process? How do they intersect? So that you guys can better understand how to work with your doc about what's going on. I think one of the important things also to talk about here is, as much as things may seem simple on a slide, they're very complicated, as is the world of Parkinson's, right? And so if we talked about Parkinson's in a general sense, it's always unfair, right? Because 1/3 of folks don't have tremor, and some people never fluctuate, and other people have these roller coaster effects. So it's really hard to generalize in this condition. And really, probably, if we were giving this talk and it's 30 years from now, we'd be talking about what's your gene subtype, and you should probably go to conference A versus, oh, if you have Parkin gene mutation B, you're going to conference B, and they're going to be completely different treatments. But we're sort of stuck generalizing, and in doing so, sometimes treatments that may work for your next door neighbor are not going to work for you. So just bear in mind that these generalities are a little hit or miss, and it's always best sort of regrouping with whoever manages your Parkinson's and making sure that we sort of find the best fit. So objectives. Most neurologists are a little bit nerdy. So we like to go back, nerdy, nerds at heart. We like to go back to the science of things. And we like to think about what's going on in the brain or in the other organ systems of the body. And how does this disease come about? And then we'll talk about, well, what should the medicines be? And then we'll talk about, well, what are the medicines that we have that can treat this condition? So we're gonna get pretty nerdy in the beginning, okay? And if things get confusing, raise a hand, okay? I'm happy to sort of take a step back, but you are gonna see some diagrams in here. And some of the science may be hopefully understandable, but if it's not, just let me know, okay? Medication options. So then we're going to go through what we know about the science, and we're going to talk about how do these medicines work, and hopefully you'll sort of follow along about it actually makes sense a little bit. We'll take a break, and then we're going to come back and talk a little bit more about motor fluctuations. So symptoms that may come and go in relationship to dopamine levels or other aspects of the daily cycle. Okay, we'll talk about more advanced therapeutics if oral medications are not the best strategy. We'll talk about some rescue medications and meds in the pipeline. I don't know if we'll have time today. So if we have to skip that, it's okay. We can just tap on the screen. So, yep, got it. Okay, so we're gonna start with where we think the problem may be. We're going to start in the brain. And you guys may have heard that in Parkinson's, the brain is like not the whole story. There's aspects of the nose and the GI tract that are also involved. I'm going to simplify it and not talk about non-motor symptoms today. We're just going to talk about motor symptoms. And motor symptoms really do arise from brain pathology, so problems in the brain, okay? When you learn about the brain in a general sense, you usually learn about, okay, there's frontal lobes, and there's temporal lobes, and a parietal lobe, and occipital lobes. Problem's not there. It's not in any one of those lobes in particular. Problem is deeper. So if you take the two hemispheres of the brain, and if you open them up and you look deep inside, you get this really complicated circuit called the basal ganglia. Many neurologists actually hate this circuit, okay? I deeply love it, but that's where the problem is. It's in the basal ganglia. So again, take these hemispheres apart, look deep inside, and there's these complicated structures here you may have sort of read about. If you ever read about Parkinson's disease and how it comes about, in particular, you may have heard about this, that sometimes people call the STN, or this, the GPI, you may have heard about in relation to DBS, deep brain stimulation. And so, great, cool, the problems, we're getting a little closer. Now, what I'm gonna sort of stretch your imaginations to is, it's not just that, it's not just a blob, but within those blob structures, there's actually many, 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 many cells. Each one of those colored portions of the diagram is thousands upon thousands of brain cells or neurons, right? And they form this really complicated network throughout the brain, throughout the body, but also in that deep basal ganglia structure there. And these cells talk to each other. So the cells are made up. Let's see, I don't know if the Zoom people can see this, but here, for example, is the cell body. So it's like basically a circle or an oval or sort of like a little blob where most of the work happens. These cells make power, if you will. They make proteins, okay? They make different chemicals, and they have these really long projections to help connect to the next cell, okay? The next neuron is what we call it. And how do they talk to each other? Well, some talk directly with electricity, and some talk by using chemicals. And there's many different chemicals that are used in the brain to connect one neuron to the next. And it depends if the signal's going to the right or to the left or deep or shallow. And you may have heard of some of these chemicals: acetylcholine, serotonin, dopamine, norepinephrine, adrenaline, right? All of these things. Oh yeah, I've heard of that before. I didn't know the brain used that. So the big story in Parkinson's is what chemical, you guys know? Dopamine. Yeah, good, okay. And is it the only story? No. So again, 30 years from now, they'd wonder, oh my gosh, Dr. Solis-Cohen just talked about dopamine. What, did she forget about all the other chemicals there? So we're learning about this. And we know that the major player is dopamine now, but we know that to a lesser degree, these other chemicals are also really important in signaling and creating motor networks, okay? Now, okay, I'm gonna take where one cell talks to the next, is this sort of highlighted region here. And I'm gonna, I think, throw it into a cartoon, hopefully, or, oh, not yet, okay. It's sort of a cartoon, but this magnifies it. It's one projection talking to another. And across this little gap, we call it a synapse, if you will. It's a little space. It's very, very tiny. The dopamine will transfer, or the acetylcholine will transfer, okay? Usually cells will use a chemical to cross that gap, rarely electricity, okay?
Does it actually cross the gap, or does it stimulate a response in a receptor?
It crosses, so a little chemical has to cross that synapse and latch onto a receptor that's on the other side, okay? But not all neurons talk that way. Some talk directly with an electrical change. That's just a minority of them, and we're not really interested in that today for medicines anyway. We're talking about how can we modulate the ones that talk by chemicals? Okay, it's a good question. This is what I thought I was going to see next. So, and to your question, we've got cell number 1 stretching its arm down, its axon down, and it has these little vesicles. So these little pouches of chemicals, if you will. And for this neuron, dopamine is the chemical it's going to use to talk to the next cell, right? So it's got its pocketed dopamine, and when it's ready, it'll release it into this synapse, this very small gap between the two cells, okay? And by osmosis, it just sort of travels and it'll hit a receptor. By hitting a receptor, the second cell will be activated and the signal will travel downstream. The signaling within the cell is a little bit different. We're not going to talk about that today, okay? But what we're talking about is how one cell activates the second cell. Make sense? And though we're talking about dopamine, there's many other chemicals in the brain. I think that's all I wanted to say here. Okay, any questions so far? Okay, so far? Okay. Okay, so how does this all circle back to Parkinson's? We already said, well, this is a dopamine story primarily, right? We're talking about a reduction in that dopamine signaling medicine chemical. So that picture that I just showed you, which was going vertically, now it's going horizontally, okay? So we've got the first cell talking to the second cell, using some dopamine to bridge that gap, okay? In Parkinson's disease, and this is a pretty big exaggeration, there's a reduction of dopamine here, okay? And so that's leading to an abnormal motor circuit. And where is this happening in the brain? Well, most of the dopamine producing neurons are in that basal ganglia that I showed you the cartoon of. And in particular, I had highlighted this substantia nigra. I said STN for people who have heard about PBS, may have heard about before. And if you sort of cut the head like this and look top down, got the eyeballs here and the nose there, right? And deep, where this, probably the lower portion of the basal ganglia sits, is this black region here, black-brown region, that's the substantia nigra. And what we know is that it should look like this. The reason it is called substantia nigra, it's black stuff. So when the neuroanatomists were studying the brain and they did autopsies, post-mortem, like, oh, we'll just call this stuff black stuff. And that's really where it got its name from. It's Latin for black stuff. And what they found was in Parkinson's individuals, it's still blacker, but you can see there's a difference in the pigmentation. Much attenuated, right? Yeah. And so that was a clear difference in the brains of individuals with Parkinson's disease. And so let's say, well, what's going on? Where are all these dopamine producing neurons going? Why are they not there? What's happening to them?
Is it the neurons that are reduced, or is it the dopamine that they're producing?
Both. Both.
Both?
First, it's the dopamine, and then it's the neurons. Mm-hmm.
Okay.
But it's a selective loss of the dopamine producing neurons. So there's both. Depends on what stage. You ask a lot of good questions.
Oh, thanks.
Depends on what stage you're in. So I don't know if you guys have ever heard these terms before: Lewy body, alpha-synuclein. Okay. We're going to try to connect the dots here now. In dopamine producing cells, if you look under a microscope, so we're talking about, this is that individual cell body, okay? And its arm, it has a couple arms here. This is one arm. The other one is traveling, but it's outside of the page, so it looks like it ends, okay? But what you see here is something we shouldn't see. It's actually a brown blob that has nothing to do with this. different, okay? But this is abnormal. And this is called the Lewy body, okay? And these parts of the cell were noticed in individuals who have Parkinson's disease, but also Lewy body dementia. They're actually quite similar, what's going on. And if you take apart this, what they found is that second word, alpha-synuclein. Alpha-synuclein is a protein everybody has. And we have it in different organ systems, but just so happens that in the brain, this protein called alpha-synuclein, which normally folds in a very neat way, it misfolds in Parkinson's. So it misfolds and the body doesn't recognize it anymore. Does that make sense? The body's like, I don't know what this stuff is. We'll put it in a Lewy body. And so instead of having normal, how should I say it? Like a normal recycling system in your body, you see a piece of trash and throw it out, right? The alpha-synuclein that's misfolded tricks the body. The body doesn't know what to do with it anymore. It puts it in a special like little pouch called a Lewy body, and that's there. But then what happens is over time, that causes dysfunction of how this brain cell works. It doesn't make enough dopamine. Yeah. And then if it gets to be so much misfolding of the alpha-synuclein, then that dopamine producing neuron may die. So then the population of dopamine producing cells is reduced also. So that's how this happens.
All right, so we put a misfolded chemical in the back shelf of the closet. And we keep doing that until the closet can't hold anything.
Bingo, exactly. So this is what we know of the problem. I'm sure there's a lot left to figure out, but this is what I can tell you so far, okay? There's been a lot of science about, well, how do we tell the body that this is trash and just go pick it up and throw it out, right? How do we tell the body to rectify the misfolded protein, right? Can we tell the body to fold it correctly, right? Can we just stop this abnormal folding and the rest of it will fold normally? All that stuff, that's where we're going. We're not there yet. But that's pretty cool. And as a neurologist in the field of Parkinson's, it's a pretty exciting time because they're testing alpha-synuclein antibodies. So they're testing antibodies against the misfolded alpha-synuclein protein. They're in phase 2 and phase 3 trials. So I'm hopeful. It's hard to understand like what people are studying until you sort of come back to the science.
Any progress? Have we got to the point where we've got an antibody that can actually go?
We have 2 antibodies in phase 3 clinical trials, and they enrolled in Denver during COVID, and they're analyzing data. Yeah. Okay. Yeah.
Second order effects, like do they only attack misfolded proteins?
So hopefully yes, but I wasn't part of those trials. So I'm not privy to, yeah. Okay, let's see. I stuck this in. Why did I stick this in?
Pretty colors.
So what we have on the y-axis is we have the percent of dopamine neurons. And what we have here is what happens as age progresses, right? So we talked about it in a general sense, but now let's talk about what happens as a person gets older, okay? In normal aging, the green line up top, you start with your full dopamine producing population, okay? All of those neurons that make dopamine. And the green line does not stay horizontal, right? So even with age, there is some loss in the dopamine population that happens. And, you know, you wonder, people do get slower when they get older, right? You move a little bit more different than you did, exactly. So is that dopamine reduction contributing to that just normal aging process? Yeah, sure, right? Let's see, what line is next? So IPD is idiopathic Parkinson's disease. And idiopathic just means we can't blame it on something else. So it's just there, okay? And this is what the most common form of Parkinson's disease is thought to be. And what you see here is over time, a person will lose their dopamine producing ability, their neurons and their ability. And when they get to about half of their population, it's reported to be somewhere between 40 and 60% loss of the dopamine production. That's when a person will have motor symptoms obvious. You can imagine the disease has been going on for years, sometimes decades, where they may have loss of sense of smell, may have constipation, REM sleep behavior disorder, or other non-motor symptoms. That's a whole other can of worms, okay? But you cross this threshold and then around here or somewhere here, you get the diagnosis, right? But it's not a static process. Like this continues to happen, right? The yellow line is a little bit less pertinent to this discussion, but it brings up the fact that to have dopamine reduction, genes are important. Environmental exposures like pesticide, or working in certain chemical settings in a person's life can be contributory. Early onset PD, so there's a certain subset of individuals who may lose dopamine more rapidly than this blue line. And again, we have many different subtypes. We shouldn't be merging these all to one line, right? So just sort of thinking a little bit more differently about your line may be different than somebody else's line. It's not uncommon that I'll meet an individual who's met a friend or a family and they said, well, oh my gosh, this person declined in this amount of time. And they can't even have a conversation with me about medicine because they were so scarred by this other person's experience. Which line are you on? Okay. Just it's important to think that everybody's sort of different here. Okay, so I put some arrows in here because let's say you meet your neurologist in clinic, right? And you're sort of early on after your diagnosis. Your movement disorder neurologist has to replace this amount of dopamine, right? Year 1, year 2, year 3. Time goes on. That little bit of medicine was working fine. Now what happens? How much medicine does your neurologist have to replace? More, right? And then time goes on, and what is that bucket? That bucket is bigger, right? So now they're replacing this. And this is why it seems like there's an expiration date on your medicine, right? And medicine only worked for 5 years. Well, your medicine is working the whole time, but this bucket's getting bigger, right? And so this is what's going on. So think about that. Okay, so now we're sort of going to regroup here. We learned a sort of the lay of the land. We learned about the dopamine neurons. We learned about how the disease kind of changes over time. And we're stuck with this problem of a dopamine deficit. So how can we fix it? Can we just sort of come up with all these ideas of fixing it? And then we'll sort of say, what can we translate into a pill? That's where we're going next, okay? So can we give you dopamine? Yeah, sure, let's give you some dopamine. Can we give you the precursor to dopamine called levodopa? Yeah, sure, we can do that. Can we keep your dopamine so that we can prevent its breakdown? Sure. Can we act on the dopamine receptor without even giving you dopamine? Yep. Can we activate the receiving cell number 2, okay, with a non-dopamine chemical? Yeah, we can do that, okay? Can we regenerate dopamine neurons? Not yet, right? Be pretty nice. But the whole concept of stem cells and research looking at stem cells primarily in Texas is really looking into that. They're more like phase 2 right now in trials. So it's a little bit further away from where we're going, but people are looking into that. And then can we remove alpha smoothing? We kind of talked about this. One thing that I have to modify in terms of what I just said on this slide was you can't get dopamine directly, but you can give a precursor to it. We'll talk about that. Questions so far?
Yeah. This, the introduction of additional dopamine doesn't seems almost alien to me. You can dump lots of chemicals into a body, but that's not the purpose of the dopamine. And it has to be released in response to events, triggering events that are mentally derived. You're trying to signal one thing to the other. You just can't dump a lot of dopamine into the system and expect the brain to function properly, can you?
You're right. That's why I modified my last statement.
Okay, all right.
So the concept of giving dopamine itself was something that was tried in the 1930s, 1940s.
Yeah.
And that really made people unwell. It made people vomit and flush and feel unwell. So we don't give dopamine directly. We give levodopa.
Yeah, and I see that in that case.
Yeah. And what we're trying to do is we're trying to allow the population of neurons that we have, the population of dopamine cells that we have, to make more of these vesicles, more of these stores of dopamine in this terminal so that they can release it in a way that's natural to them, so that they can't tell the difference between what they intrinsically made in terms of dopamine and what was then given to them that they made into dopamine. So we're basically going to overwhelm the cell with a precursor to dopamine so that they'll make their own. I'll show you on the next slide.
Sure.
Okay.
Can I ask a question?
Yeah, please.
So can you elaborate more on what you said about
Idiopathic. Yeah. So we have this term in medicine, idiopathic, this, that, or the other. And generally that means that it's not secondary to something that we can blame it on, that it, let's see. Have you ever heard of essential hypertension? That doesn't strike well either. Okay.
No.
So Agent Orange is known to be causing Parkinson's. So that would be
A secondary
secondary.
Parkinson's, yeah. But when we use this term idiopathic Parkinson's disease, we generally mean the type of Parkinson's that probably has genetic underpinning, okay? But it's not related to something that's clearly an environmental exposure, clearly a medication exposure, not related to a stroke, okay? And there's no other underlying tumor or bleed that's there. So there's nothing like structurally wrong on an MRI or other sort of exposure that a person had, okay? If it was, then we would call it a secondary Parkinsonism. Anyway, the terminology is a little archaic. So you can get rid of the I and it would be fine. Just regular run-of-the-mill Parkinson's disease and idiopathic Parkinson's disease are synonymous, basically.
I'd like to ask you a question. I'm here because of my husband.
Yeah.
And he just cannot face the fact that he has Parkinson's. And he probably has had it for a long time. So he has been diagnosed with a DAT scan.
Yeah.
And my question is this. He's on Carbidopa and levodopa.
Yeah.
But he doesn't take it all the time.
Yeah.
He regulates himself. He's gone for months without taking it, then decides to take it. What happens to me?
I'll come back to that. So let me just educate the other folks. A DAT scan, DAT scan, dopamine DA, T is the transporter scan. So it looks like how your brain uses dopamine in a communication sort of a signal, okay? And allows us to see if there's a dopamine level are normal or if the dopamine level is low. So one thing that I always tell people in my clinic is that a dopamine scan that's abnormal is a dopamine scan that's abnormal. It is not 100% synonymous with Parkinson's disease. About 80% of the time you get a DAT scan that's abnormal, it is Parkinson's disease. It is that idiopathic, regular run-of-the-mill Parkinson's disease. 20% of the time, it's a Parkinsonism. Some people may say atypical Parkinsonism, Parkinson's plus. It has some sort of more exotic features to it that are not expected in run-of-the-mill Parkinson's disease. So when people said, well, I definitely have Parkinson's disease because I had an abnormal DAT scan, we've got some work to do on educating you about other things that this may actually be. So that's what like sort of a DAT scan allows us to look directly at the dopamine level. It's not an MRI, it's not a CAT scan, it's something called a SPECT scan. So it just really highlights the dopamine level. It's really cheating for neurologists. It's really helpful sometimes when a person has arthritis or they've had a stroke, they've had neuropathy, they've got all these other neurologic problems and there's too many confounding variables. But movement disorder neurologists don't always get it because we can diagnose it clinically, we can monitor response to medicine. So for me, I'll use it sort of sparingly. I'll also use it when a person is not really accepting of their diagnosis because it's the closest thing that will help us show you that something's wrong. And then sometimes, you know, it's important for a person to say, oh, okay, well, maybe this is abnormal. But I can imagine that going to a doctor and having them do this, and then you walk away with a neurologic disease does not feel good, right? It does not feel good. So sometimes having a test that supports that seems like it is the right thing to do. Does that make sense?
It does.
So the question of the carbidopa, levodopa, let's go to that. Okay, so I'm hopefully going to answer it when I go over those slides. Okay, okay. Okay, this is an actual diagram from an actual neurology textbook, and it's big, it's complicated. So, but this is sort of the only way to understand how Parkinson's medicines work. So I'll walk you through it. We've got a projection from a neuron. Okay, so a projection from a brain cell that is going up the page. Okay, so the signal is going to transfer up this way. Okay, and this is cell 1. It's making its little dopamine vesicles here, and it's going to release them into this synapse here. And then it's going to trigger neuron number 2 with a couple different receptors. They're not all dopamine, but there's dopamine 1, there's dopamine 2, and something called an NMDA receptor, which is totally different. And let's see, where we're going to start is the concept of levodopa substitution. So levodopa is a precursor to dopamine, which are these little orange dots. And levodopa is basically like an amino acid, so it's a breakdown of protein, okay? And it requires this enzyme that you can't read, but it's amino acid decarboxylase. And it basically converts this dopamine within that arm projection of the neuron. Okay, so back in the early 1900s, when they were first trying to come up with medicine and they gave dopamine, people were vomiting and flushing and nauseous because the dopamine, when it's in the bloodstream, causes problems for blood vessels, okay, or the gut, or all these other structures, and it wouldn't cross into the brain, the dopamine, but the levodopa does. So therein lies the difference. I'm sorry, I didn't clarify that then. So dopamine alone, we're not able to deliver to the brain well, but levodopa we can, okay? One other thing I want to step back and mention is that the brain is covered with like a few layers of saran wrap, cellophane. We call them meninges, if you ever heard of that. But there's a few layers of like shrink wrap over your brain. And that shrink wrap is really important to prevent toxic chemicals from impacting how you think. It's basically, you know, a survival mechanism, if you will, if you were to have a toxic exposure. So your whole brain and spinal cord is enwrapped in this protective layer. But if we want medications to act on our central nervous system, our brain and our spinal cord, we have to cross that. We call it the blood-brain barrier, okay? And so we have to get a medicine not to act on the rest of the body, to go from the blood through the blood-brain barrier and impact only the dopamine neurons, right? Yeah. Sure. Yeah. Seems reasonable.
Yeah.
So everybody was really excited when this came about, carbidopa, levodopa. And I like to call it your dopamine supplement, okay? Because it helps you make more dopamine, okay? So this is something that we've had for more than 50 years. That's a long time. It's been in studies since the 1950s. I think it was, did I put it on here? I think it was 67 or 68 since it's been prescribed by physicians. And levodopa is the active ingredient. So that's the part that's really giving you the motor benefit. It's a amino acid, so it's a building block of a protein. And generally, you take it in a little pill. It goes in your digestive tract all the way to your small intestine. It transfers over into your bloodstream there. It circulates in your blood, has to cross that shrink wrap around your brain, right? That blood-brain barrier. And then it has to work on converting levodopa to dopamine via that protein that you have. So your intrinsic enzymes like, oh, levodopa, I know what to do with it. Let's make more dopamine. And so it makes more dopamine and puts it in those vesicles that are in those dopamine neurons. So it doesn't make more dopamine neurons, but it allows your cells to make more dopamine by itself.
If and only AAD works.
Correct. And we do think AAD works because this works. There's nothing that we know that AAD doesn't work. It still works. It's like a rate limiting equation, right? A plus B goes to C. If you just give yourself so much A, you'll make more C eventually, as long as the math works, is what you're saying. Exactly. And we think the math works or else this medicine shouldn't work, and it does. So, why carbidopa? Well, carbidopa prevents levodopa from getting converted to dopamine in the bloodstream. If all this levodopa would get converted to dopamine in the bloodstream, then you'd be vomiting, flushing, diarrhea, and all the other unpleasantries that used to happen when people got just dopamine. So, because the carbidopa is there, medicine is better tolerated, okay? And it's always given in combination, except there's one inhaled form we'll come to later, okay? Side effects: nausea, vomiting, lightheadedness, low blood pressure. Those are, the first four are when people are really sensitive to this medicine, and some of it gets converted in the bloodstream still, despite the carbidopa. So the first four tell me there's still some peripheral conversion, meaning still some conversion in the bloodstream. Sometimes I just give them more carbidopa. In Colorado, I don't know why, but it's very expensive here. On the East Coast, it was not expensive. So we've come up with better ways of trying to deal with that in Colorado, which is sometimes an anti-nausea medicine. And I've had a lot of people say, well, Dr. Solis-Cohen, I really don't want to take 2 meds. So I'm just not going to take my carbidopa, levodopa. I'm just not going to take it. And how do they do? Slow, shake, right? So it stinks. It stinks when you see a person, and I know I can make them better, but they don't want to take 2 meds, right? It's hard. It's hard on both ends. I get it. I also don't like taking medicine myself. So I don't disagree with that. But sometimes you sort of have to try things in this condition. And sometimes when one medicine does cause side effects, listen to your doctor about, what they've got to try to help you with that. Confusion, hallucinations. Dopamine can contribute to those, and that's a brain effect. That's not a blood effect. Dyskinesia is a sort of wiggly extra movement. We'll talk about it in a little bit. Dyskinesia, not everybody gets it. And it is not all your medicine's fault. It is a little bit of Parkinson's with a little bit of dopamine supplementing medicine that causes dyskinesia together, okay? Let's see. So people ask me, like, what's going to happen when I start this medicine? What should I expect? And I said, well, you know, the things that you could expect are improvements in your tremor, in your slowness, in your stiffness. But really, everybody responds differently. Some people have benefit of their tremor with not a lot of improvement of the other stuff, or vice versa. So really, it's important for them to come back and tell me what got better and what didn't. Because I'll tell you, everybody, if you know we had Parkinson, everybody took this medicine, they'd respond differently. That makes sense. So we want to know from you guys, or whoever has it, what actually does happen, what gets better and what doesn't.
What you're describing is what happens, what we can do in order to increase the production of dopamine within the brain through the addition of carbidopa. At least that's what I heard. Did I get that right?
Yeah.
What causes, what natural activity within the body causes the dopamine to be reduced to begin with? Are we missing, is there something in the, for example, the diet? If I don't eat enough, I don't know, corn, does the dopamine levels of the brain decrease? Is there something that we're missing up front?
No, so in normal aging, so you're talking about like, why does the green line go down?
Yeah.
Basically here, like
Yeah.
why would that even happen? So the unfortunate part of aging is that we lose brain neurons with age. So the brain atrophies, it shrinks as we get older. And that process happens as early as late 20s, early 30s.
Yeah.
So we're losing neurons throughout the brain. We're not disproportionately losing it in the basal ganglia where the dopamine is produced. We're just losing it. So I suspect it's that, but it's not something about diet. There, you know, people have looked at nutritional studies in Parkinson's, and there was some evidence that Mediterranean diet may be a better diet, if you will, but it's not like a person in one part of this world has later onset than other people. You know, otherwise we'd all follow a certain lifestyle of choice, but we've not found that. So we don't think that there's a supplement thing that's going on. We don't think that there's really like a cultural thing that's going on. We do know there's a genetic component to this.
It's all genetic.
Yeah, yeah. And there's environmental triggers, but it's really not a nutritionally based process. So carbidopa, we talked about this as blocking the unwanted side effects of levodopa if that were to be taken alone. We want to limit how much levodopa is getting converted to dopamine outside of the brain. If dopamine were to, if we were to convert levodopa to dopamine in the gut, that's what causes the nausea. And if we were to convert it in the bloodstream, we'd get low blood pressure. So these are side effects that come about from the medicine, and that's really why those happen. Okay, how much carbidopa levodopa do you need? Or what is the ratio between those two elements? It should always be 1 to 4. 1 to 4, 25 to 100. There is a 10 to 100 pill. Side effects, not great. So some people can get away with the 1 to 10 ratio, but it's an easy fix. So I have some people who come to me and say, I'm really nauseous, and we'll look at the pill. It's the 10 to 100 strength. We should really not be prescribing that anymore. We should only be prescribing the 25 to 100 pill. So most general neurologists know this now, but it's an easy fix for some people who get nauseous. So if your pill doesn't say 25 to 100 or a ratio in 1 to 4, you should talk to your doctor. So it's not a surprise that a medicine that we've had and we still use for more than 50 years, and we believe is one of the most potent medicines in Parkinson's disease. We have many different forms of it. There's a lot of forms of it. So carbidopa levodopa IR, immediate release. Some people will call Cinemat. I don't know if you've heard of Cinemat before. Yeah. So where does that come from? Emesis, that's vomiting. Sin, without vomiting. So back in the day, when these two were put together, they came up with this name, without vomiting. That was the trade name for their drug. That was how thrilled these manufacturers were to come up with a pill that people could take to supplement dopamine levels without leading to vomiting. Okay, so that's pretty funny, I think. Carbidopa levodopa CR, sometimes also known as ER. That's a tablet. That's probably the second best form of this medicine. Actually, no, third best. This is not an expensive form, the second one. You can get it as a generic product over the with your doctor, but it's not always the best variety because there's some changes in how one pill versus the second pill will be absorbed. So there's some absorption issues. It's not always as reliable. The third form, I think is probably the second best form, is Rytary. Rytary is a capsule. There's 4 different strengths. They have different colors on them. And Rytary has some obnoxious numbers associated with it. So it's not 25-100, it's something decimal point with something that ends in a 5. So I forget the first half of the number and call it a 95 or 145 or 195 or 245. We just talked about the levodopa component. Rytary did that so the pharmacist and neurologist would not make medication errors with patients. So they made the numbers so obvious when a person's on Rytary. Sometimes people get confused with these two because the numbers are the same. So just always be very clear with your doctor which form you're on. Always bring your pill bottles to make sure that IR and the other tablet form of the extended release are not messed up. When a person is in the hospital, there is something called an orally disintegrating tablet that you can put in the mouth. It gets disintegrated in the mouth. And so if a person has some sort of surgical procedure and they can't swallow, it can be delivered that way. Duopa, an intestinal gel infusion, is a sort of gel type quality medication that's not a tablet, but it requires a PEG tube. So it requires a tube directly into the intestine. And it actually is delivered by a little infusion pump that you carry as like a fanny pack or on a little vest. And for some people, it's make or break in symptom control. A lot of my patients are really active as Coloradans and don't want an infusion pump, but sometimes it's medically necessary. Inhaled levodopa. So this is the only one that's alone. You notice there's no carbidopa, but that medicine is a rescue medicine for people who have offs, sudden offs. And they use this to rescue themselves back into an on. We'll talk more about that. And it requires that you are on carbidopa levodopa. So you're taking carbidopa levodopa, you're getting the carbidopa from that way. And this one is just a little whiff of levodopa. And then in November, we got, I think they're saying Divi, but sure. I don't know. It's a fractionated immediate release. So it's a 25-100, sort of like the first one, but instead of having a little crumble effect with that tablet, a lot of people know when their doc says take a half tab, sometimes I don't know which half to take, they're not even. This one will allow you to split it into fourths pretty easily. So that's the newest thing, not always medically necessary depending on the person. All right, so to eat or not eat with levodopa, talk to your doctor about it. If you read the pill bottle, it will say don't take with food. Okay, it'll say take on an empty stomach. But really, I give different answers to different people, depending on what's going on. I've had some people avoid eating, become malnourished, because they were trying to always take their pills on an empty stomach. They were taking their pills every 2 hours. And you can imagine that's limiting nutrition. The real science behind it is based on where this medicine is absorbed, small intestine. And it is competing with amino acid absorption. What are amino acids? Proteins. So the real story is when you eat a high protein meal and take your pill, both of those are vying for the same uptake in the small intestine. So it's best to eat carbohydrates or fatty foods with your pills and not high protein meals. But that's sort of hard to do because, right, all food sort of has a little mix of everything in it. So if you were trying to maximize absorption of your carbidopa levodopa, well, then you're going to avoid protein 30 minutes before and 60 minutes after levodopa, okay? And that may optimize absorption for you. Can you ignore this recommendation? It's important to talk to your doctor and ask them if you can or if you cannot, what's more, you know, what's going on with your life, with your other sort of health status issues that you have. Often when you're starting this medicine, if you have any nausea, one way to be to increase tolerability is to eat it with some crackers or, you know, take your medicines with a little bit of carbohydrate. It will help. Yes.
I'm here with my friend, and I think we fight more about this than anything.
Yeah.
She says, well, my Parkinson's friend steak means I can't take it with steak, but I could take it with yogurt or cheese or et cetera, et cetera. So, and I said, don't take it with anything. Well, I can't. I need to eat most all the time. She's thin and tiny. And so in the morning at 6:30 with her first dose, then she needs a piece of toast. But she always has a slice of cheese and some jam. Then she has breakfast an hour and a half later.
I think there's a lot to unpack there. So, and I mean that respectfully, but I think that I think there's a couple things going on. So one is Parkinson's affects the gut, and we didn't even touch that today. But Parkinson's can limit how fast pills actually move down the digestive tract, how fast food moves down the digestive tract. Even the stomach can actually hold pills at times. So people have dose failures too. So that's a whole other story about how the GI tract is disturbed in this condition, to say the least. So there's that. The other thing is that tolerability plays a huge role. So what people have sort of become accustomed to having better outcomes with their pills, they really latch on to, right? It's like a religion to some degree. And then the other thing that's important in motor function is the placebo effect. So there is a really high rate of placebo effect in Parkinson's, and that ruins some of our Parkinson's research, quite honestly. I don't mean ruin it in a bad way, but we often need more studies to demonstrate an effect because there is so much generated by giving a placebo in Parkinson's by virtue of it affecting the dopamine circuit. So that's where the placebo response comes from, the dopamine circuit. And because we're giving dopamine medicines, we often generate placebo response to much higher levels in Parkinson's. And so when there's an association in Parkinson's, it almost becomes a little compulsive at times because there's a sort of a dysregulation of the reward response system too. So if things seem a little bit like, well, really, is that all right? It's a little bit of everything going on there. So that's why I said it like that. There is really a lot to unpack. I think that you're going to be hard to prove that person wrong. So I think you have to be as respectful as you can. And some of it's based on truth and some of it may be based on just these associations that have come about along the way.
Let's say a word when she pops a little ice cream every 2 hours, because that's to me, straight up dopamine pleasure.
Yeah, exactly. Exactly. The other thing is impulse control disorders are present in Parkinson's disease. And so people have different impulses and compulsions related to all sorts of life, cleaning, eating, gambling, sex, all sorts of different things. And so there sometimes even is that with medications.
What's the highest dose of carbidopa?
Great question. There is no highest dose. It is all determined about how deep that arrow was for the dopamine deficit. So as time goes on, as that bucket gets bigger, your dose is getting bigger. And usually it's not what is the highest possible dose. It's usually, well, what side effect are you having that limits me to increase it further? A starter dose, we don't go above 9 pills per day. So 25-100, 9 pills per day. We're not going to go above that in the first few years, definitely. But later on, I've had 30 pills. So, yeah. But that's a good question. So common misconceptions. I'm sort of like already gearing you guys to understand why some of these are misconceptions. You don't have to be so worried about these, but these are things that I hear in the clinic. If I take levodopa early on, it will stop working after a few years. So I have some people not take any medicines for 5 years plus because they think that there's an expiration date. I'm avoiding levodopa so I will not get dyskinesias. I'm scared levodopa will cause progression of my disease itself. I will develop a tolerance in the future. I shouldn't waste my treatment on mild symptoms. Okay, these are all things that we're talking about day in and day out. And I take you back to this, right? So if you think about it,
anyway.
I shouldn't waste my treatment on my mild symptoms. Well, you've lost the opportunity to treat things when they're sort of less of a deficit and where the treatment feels beautiful here. Or it works pretty well. You can go back to swimming and jogging and whatever it is, skiing, whatever, you know? So those early years are where I sort of say, let's optimize it. Let's get it, right? Let's enjoy, right? And then here's another thing, delayed start trials. So this is New England Journal of Medicine. This is 2019. There's a couple other studies too, but this is the New England Journal of Medicine, so we highlight it. Early levodopa versus delayed treatment. So they actually studied people that started levodopa early and started levodopa later. And they said the people that were on levodopa earlier had better quality of life in that early phase. And they did not have more or earlier dyskinesias than the people that started later. Okay. And disease did not progress faster. There was some literature early on that was talking about levodopa causing inflammation. And people were very reluctant because they thought their disease was going to progress faster. And so if you talk to neurologists who are like in their 80s, they'll say, yeah, no, we never gave people levodopa early on. We gave them something called a dopamine agonist or a different class. We always avoided that stuff. Are they right? No, right? So science is always changing, right? And who knows what we're going to say in 30 years from now. But it's important to know that this medicine is not doing you a disservice as far as how the science is telling us now. Oh yeah, and some people wonder if whether or not this is early levodopa causes the roller coaster effect with ons and offs, and it didn't show that either. So
when was that published?
This is 2019.
Okay, so it's relatively recent.
Yeah, right. And there's other studies that show this, but this is a recent study that, yeah. Okay, so that's the levodopa, and that's sort of a crux of how we treat this condition. The question about not taking it and taking it. So it's symptom management. It doesn't halt progression of disease. And so really, are you doing yourself a disservice by taking it and not taking it? I guess not. But I think her quality of life is suffering. You know?
For about 3 months.
I'm sorry. The other thing I would say is that this medicine should always be increased and decreased slowly. So if you take big jumps and go from 2 pills to no pill, or, you know, like that, side effects are not great. So this is something that we always recommend. Follow slow increases or decreases with your doctor for just better tolerability. All right, where am I going next? I'm talking about dopamine agonist. So dopamine agonists are things that look like dopamine because they fit into the dopamine receptor so well that the brain thinks that they're dopamine. And they trigger the second cell, but there's no extra dopamine. It's just, they're a mimicker, okay? They're a lookalike.
So what?
What? So what? Yeah.
If the receptor thinks it's got dopamine,
It's got
and
dopamine.
it acts like it's got dopamine,
Right.
is it a duck or not?
So there's a few different forms of this. There is pramipexole Mirapex, ropinirole Requip, reticotine Nucro, that's a patch, and apomorphine, which is an injection, Evican. And the first 3 are also marketed heavily as restless legs medicine, which they are. And it just so happens that carbidopa, levodopa, guess what? It helps restless legs too. All of these dopamine medicines actually do help restless legs. Restless legs is more common in Parkinson's than the general population. But it doesn't mean that everybody who has restless legs is going to get Parkinson's or has Parkinson's, right? So just bear that in mind, okay? But if you see it on TV for this, that, or the other, those are also treating them. Let's see. Dopamine agonist, like we said, it acts on the dopamine receptor. It's a pill or a patch. Oh, I forgot. It's an injection too, so that should say that. These can come in immediate release or extended release formulations, and they can be taken alone or with carbidopa levodopa. Side effects. Usually when we're sort of talking about medicine management, what I'm trying to sort of think about is how can I get you the potency that you need, and bearing in mind all the other potential medical problems that you have, to come up with the most tolerable solution for you without over medicating you. So there's a little bit of that going on in our heads when we're trying to pick for you. Generally, dopamine agonists are tolerated better age 65 or less. And as a person is age 75 or more, the potential for hallucinations, confusion, and sleepiness increase. So folks in my clinic in particular will know that when I look at their medicines list, I'm like, oh, we're gonna have to get you off this medicine soon because I don't want you to start hallucinating because of my medicine. So there's some of that when you go to the neurologist. They'll look at dopamine agonists, they'll look at how long you've been on it, they'll try to maybe wean that off. Doesn't always go well. Sometimes we try and people are still on their dopamine agonists, and it is what it is. Dopamine agonists are known for sleep attacks. So waves of, I don't know, it's like the after Thanksgiving wave of sleepiness that you get when you just overloaded on food, that kind of sleepiness. Yeah, just not favorable for driving, right? So that can happen. You have to build up this medicine pretty slowly. Insomnia can also happen, which is interesting because those are opposites. Confusion, hallucination, impulse control disorder. It happens rarely because of this medicine, but it happens. And nobody associates gambling with a dopamine agonist. Nobody associates, a new interest in pornography with a new medicine that their neurologist prescribed, right? And the real story is, well, it's actually not all the medicine, and it's not all the Parkinson's, but some people, because of this disease process and this dopamine agonist medicine, they get these really bad side effects. And we sort of warn people all the time, warn spouses, friends, this is a possibility. Watch the bank account, watch their behavior. And if it's a problem, we don't mess around, we take you off of it, okay? The rate of that occurring is less than 5%, but that's not nil, right? And so it's better for people to know about it and look out for it. Generally speaking, if you have these side effects and you take people off of these medicines, it goes away, okay? And it's not easy. It's not that dopamine agonists work better in everybody and carbidopa, levodopa doesn't, or vice versa. Really, for some people, one will work beautifully and they'll have a side effect from the other one. I can't always predict. So when we say some of these medicines are trial and error, that really is the honest truth, okay? But both of them are really great medicines that work well for some people and just not for others, okay? Questions? Yeah.
So Parkinson's was kind enough to send me to a summit for care partners or not the care partners. I heard that the hallucinations were not necessarily a side effect of the medication. They were part of the non-motor symptoms, a part of a psychosis that comes with that.
Both, yeah. And it depends on disease evolution. So it depends on how the condition progresses. And it also depends on whether or not that symptom or side effect goes away if you withdraw the medicine. So for some of my patients, if they were to start a medicine like this and they came back to me and was like, I'm seeing people in small animals and we get rid of the medicine and that goes away, well, that was clearly a side effect, right? It is much more likely for that to be a medicine side effect for a person who is cognitively well. So they don't have memory disturbance. They're not above age 75. They've never had any sort of shadow experience or delusion before. And I would be very reluctant to be starting this class of medicine if you're over 75 and you have short-term memory problems, or you've ever had a feeling of a shadow behind you, because I know this is going to happen. And then you're wondering, is it medicine or is it disease progression? It's probably both. Does that make sense? So it's sometimes you sort of have to pick and choose. Okay, so now the story's going to shift. And now we're going to talk about two major enzymes whose job it is to break down dopamine. They sort of clear dopamine from the synapse. So an MAOB and a COMT, they help break down dopamine so that the second cell isn't like perpetually activated, because something needs to get rid of that dopamine away so that a new activation can occur, okay? And so these are sort of our enzymes that appropriately will degrade the dopamine and the cell can get interrupted an appropriate signal, okay? What happens if we block those enzymes? What happens if I hide the MAOB or hide the COMT? Then this dopamine has more time to activate that second cell. And so it's another way to sort of trick that second neuron into thinking there's more dopamine, okay? So MAOB inhibitors So that enzyme was MAOB, but if we inhibit or if we block it, okay, we get some medicines out of it, okay? And so these are medicines that basically block that enzyme. More dopamine is allowed to remain in the synapse for a little bit longer. And there's some medicines that you may have heard of and others that may be totally foreign. The most common one these days is rastagaline or Asclect. Second most common is selegiline. These two are generic. Xadago, let's see, it's been around 3 years now that it's been FDA approved, maybe 4. I don't know, time really stood still during COVID. So I don't know what year, right? But this last one has to be taken in conjunction with other Parkinson's meds. These can be taken as a monotherapy or as a alone therapy. And there's been some studies about rastagaline, that middle one. And initially there was some thought that rastagaline could be a disease modifying medicine, meaning slow the progression of Parkinson's, okay? But that's been debunked, okay? So that is no longer what movement disorder neurologists think. You may hear it in the community. People talk about, I'm on that Asclect medicine that's going to slow the progression of my condition. It is not currently scientifically based, okay? These are less potent medicines. So often when people are on carbidopa levodopa and an MAOB, the MAOB is like not doing a whole lot, like, 5 to 10% of the work. And so sometimes we'll actually take them off of it to sort of simplify things. Let's see, you can take it once or twice a day, alone or in combination with your other medicines. There's some baggage with it. So you have to be careful about other medicines that you're taking. In antidepressants, potentially. We used to really counsel about red wine, aged cheese, and a tyramine interaction. We now think that's safe. So we don't always have to follow that, but there's a lot of problems that can come about with blood pressure, headaches, dizziness with this. Parkinson's make also have blood pressure issues of its own. Low, high, variable. And if you add this medicine to it, sometimes we're in a tricky position. So one of the medicines to use with caution. COMT inhibitor. So COMT was that other enzyme that helps remove dopamine from the synapse. The inhibitor blocks that, so then you have more, okay? And this one, you cannot take it alone. It has to be taken with carbidopa levodopa. So one of the other tools in the toolbox, it helps sort of lengthen the duration of action of carbidopa levodopa, okay? That's how it should be used. Entacapone is the generic form that we have. We used to have this combo, all 3 in 1 pill. That's actually more expensive now because it just we don't use it anymore as much anymore. So you won't really see that anymore. Argentis was released in 2020, and that does lengthen the sort of how long the carbidopa levodopa would last in the system. We do use that. Side effects. So with this first one, your urine can turn different colors, and that's disconcerting sometimes. The other side effects, though, you've seen them before, right? So it's this recurring theme that we have. We've talked about how those come about. There's an A2A receptor. All right, that wasn't in the neurology books. I drew that in. You can tell it looks a little bit different. An adenosine receptor. This was sort of an interesting story that came about. Adenosine is another receptor on the downstream dopamine neuron, and it helps activate that receptor and sort of like liberate dopamine is how we describe it. And we have a medicine that works on that called Neurodiagnostics. And it is a downstream metabolite of caffeine. So some people sort of feel a little jittery with it if there's a side effect. That's a new one in addition to the other ones you guys have already heard about. And so the science is a little bit more complicated. So I'm going to simplify it and say it downstream impacts the dopamine receptor. And it's sort of an indirect action, if you will. And for some people, it helps their other medicines work better. It's just not really a great monotherapy or a medicine by itself. All right, you guys getting totally bored yet? Well, hang in there because this one's a good one. The NMDA antagonist, another way to act on that second downstream neuron. Different mechanism of action. We don't understand the mechanism all that clearly, but this medicine works. Amantadine, originally designed as an antiviral to help with folks who had the flu, influenza. And when this medicine was used for that, they found that folks who have Parkinson's disease would have less dyskinesias. Like, oh, well, it doesn't really work very well for the flu, so let's use this in the Parkinson's world. And it helps to suppress those wiggly extra dyskinesia movements. And there's also some benefit of off time or tremor. It has a complex mechanism of action, which uses that receptor that I sort of highlighted. It's a little bit above this course today. Side effects are there, and they are not negligible. And the choice of using this medicine is something that I don't take lightly. And it really also depends on age. It depends on whether there's any cognitive impairment beforehand, any leg swelling beforehand, any dizziness beforehand. So I know I can exacerbate those things by starting this medicine, but it is a good and potent medicine. It is cleared by the kidneys, so if there's any kidney problems, we also have to think about acknowledging any kidney dysfunction. And like I said, I avoid it if there's cognitive impairment, or somebody already has a sign that they're going to have problems with hallucinations. Amantadine used to just have immediate release. It just was the generic stuff. And then, bless you, we had 2 extended release options released just before COVID. Yeah. GoCovery is an extended release once daily at night. Osmolex is once daily during the day. All 3 of them are effective. Trihexyphenidyl, almost nobody is on this for Parkinson's itself. It's primarily a dystonia medicine. Dystonia is a term that we use when there's an excess posture or contraction. You may see somebody's like neck tilted and turned, or a foot that, in Parkinson's, the most common is a cervical dystonia, or a foot inversion where the foot sort of lands on the outer edge, toes curl down. This side effects are not great. And though children do well with it, adults don't. And so usually dry mouth, confusion, constipation, and I rarely use it for this, but for other things we do. Okay, you've earned a break. And I don't know what time it is. Oh, wow. Okay, so we'll take a break.
The bathrooms, if you go out, they're just a little bit. The women's is on this side, and then the men's, you go down the hallway a little bit, straight through the past the elevators, and then right into that hallway. And then please help yourself to coffees, cookies, water.
Something that's treated.
Yes. So
yeah, so the dystonia happens both in Parkinson's and in other disorders, and it happens alone. And some Parkinson's medicines do help, but Botox is also a gold standard treatment of dystonia, and I didn't even touch that. Absolutely.
I had a friend who was like in his 30s, this was years ago. He was a tonometry tech, and the nurses were complaining they couldn't read his notes. You know, shaking or doing, so I didn't realize it. And they told him he needed to start typing and stuff. And, I think I remember him going and get that injection in his forearm or something.
Yeah. I'm just gonna. Yeah, I'm just gonna hide you.
We knew the word, it's just it's not emphasized.
It's vacuum that little part in the bedroom.
Like some tea or something? I'm like shaking. Do you want that? No, I will.
Yeah. I got it.
You were 6. Yeah. I was in the shower. But I would have thought you would have heard the doorbell.
Yeah, I don't remember.
I know, I'm just like, people don't think I'm nervous, and I'm really cold. It's really cold in here. I haven't taken my coat off, so. Yeah. Okay, good. Okay, I think so. The second day, yeah. You have to
I think so.
Yeah. Yes, we do use volunteers. Yeah. Yes.
Just share the screen real quick.
Okay, great. You good? Yeah. Do you need anything else? I'm good. Okay.
Yeah, no, I said to you.
Oh, did you?
Yeah, this was like,
What to say?
this week climbing the piano.
Okay. Yeah.
Thanks.
All right, so shall we?
Yeah.
Okay. Yeah. So the second part of it, we're not going to talk about individual medicines, no, minus like one little part. But we're going to talk about motor fluctuations. Motor fluctuations refer to ons and offs. Okay, they refer to ups and downs. They refer to having motor symptoms that respond to dopamine medicines. You may hear us say dopaminergic medicines because they either give a person's ability to increase their dopamine production or they trick you and act on that second cell. We say dopaminergic medicines increase the dopamine tone. And so when we think about ons and offs, it doesn't mean the same thing for everybody, right? So a person may have tremor only, really, and they're on maybe no tremor, and they're off maybe return of that tremor. And for the next person, they may have an arm that's very stiff that doesn't move when they walk, right? And they're off. Maybe when that's there, when the medicine has worn off, versus they're on, maybe a reduction of that symptom. Does that make sense? But not everybody has this. And so, you know, the best way to sort of think about whether or not you have this is to create a diary, to chart it out. right? When you have the times, and I'll show you some diaries. There's some pretty complicated diaries out there. And then I'll show you sort of the more simplistic version of it. But an easy question is, in the morning before you take your medicines, you feel the motor symptoms come back at that time? Or do you feel your motor symptoms come back right when you're taking your medicines, okay? Like you're due to take your medicines or you just took your medicines and they haven't yet kicked in. Another thing that's important to acknowledge is when you take that pill, it is not immediately effective. It has a long journey, right? You learned about its journey. This is going to take you at least 15 minutes after that pill enters your body to take any sort of effect, quite honestly. And usually it's 30 to 45 and less commonly 60 minutes before it takes effect. But I've had people say, I take my medicine and I get worse. Like, actually, I mean, even though that is a possibility, commonly it's that medicine didn't start working yet and you're still wearing off, even though the pill has entered your body. So important to acknowledge. That had nothing to do with the slide, but it's fine.
How often do you recommend the spacing?
Fabulous question. So guess what? It depends on the individual.
Okay.
And the half-life of medicines is what a pharmacist would say we should look at to determine how often to give this medicine. Mm-hmm. Usually it's given no less than 3 times a day, okay? But what we know is we're not talking about bloodstream levels. What we're talking about is crossing the brain, making dopamine, those synaptic vessels, those stay there. They may not act right away after you take it. So the chemistry in terms of like bloodstream levels does not translate into your hour dosing. And so it's generally 3 times a day or more frequently if you're having wearing off. The interesting thing that happens overnight is those dopamine neurons go through a restorative process. So unless you're working out overnight, doing some crazy bathroom routine where you're getting up and walking all night, you're actually building up a little dopamine store so that when you wake up in the morning, you may not feel as bad as you expect to because you hadn't taken medicine for a long time, if that makes sense. Some people will go 12 hours overnight and do quite well. Typically, that's when the bucket is smaller earlier on in the condition. And then that restorative process declines as the disease marches on because the population of neurons is less. Okay, but I have some people who say, well, these medicines don't do a thing because I wake up and I feel great and I hadn't taken them for 12 hours. So it's a little bit of a challenging discussion to have without understanding what happens. Okay, important graphs, you know, I like them. So y-axis, motor function. So let's talk about an easy case. Let's talk about just tremor. We're just treating a Parkinson's tremor, okay? In the on state, there's no tremor. In the off state, tremor comes back, okay? In the on with dyskinesia, is there tremor? Okay, you guys are very complicated. No, there's no tremor for the easy situations, okay? Make it challenging for me. So if I'm on, I hopefully don't have a tremor, okay? If I'm on with dyskinesia, I don't have a tremor and I'm sort of like a little bit dyskinetic, so I'm moving around. We're all right, tremor can occur with dyskinesia, but like that's Parkinson's 301. We're not there right now, okay? Regardless, if I can stratify the day into 3 different motor states, what I'm going to explain to you is what happens here. This is the time of day, okay? I wake up in the morning, okay? I'm a little bit low on my dopamine levels. I take my levodopa pill. My levodopa bloodstream level goes up, okay? I'm making more dopamine in my brain. But guess what? I'm still on. So I don't have a lot of tremor. Maybe just like a little bit here, and now I have a little bit less, just a little bit more. But overall, I'm well controlled without a whole lot of bothersome interfering tremor, right? So I may have some fluctuations in my blood and my brain level of dopamine, but I'm staying in this blue range where my symptoms are pretty well controlled. So yes, you can complain to your neurologist about like the tremor that happens for half an hour or this, that, or the other, but overall, pretty good, right? You're not spending time up here or with severe tremor down here. Does that make sense? Okay, now, this is early Parkinson's disease, good motor control. That's not hard. What's hard is when these undulations, these peaks and valleys cross the good motor function, okay? Now you take your pill and instead of staying in a good on state, you're on with dyskinesias. So, oh, my med's starting to work, I feel great, but oh man, these things come again. Now I'm wiggling around and it gets harder to control. The med wears off, the tremor comes back. So people come to the clinic and they're, I'm shaking. Okay, what kind of shaking are you having? I don't know, like this twisting thing happens, but then this one goes, so wow, that gets complicated, right? What is the movement that you're actually happening? Are you here? Are you here? Wow, it gets challenging, okay? Take your next pill, right? Dyskinesia, off. I'd love to say it was this easy. It's not, okay? Because sometimes what happens is you shoot up, then you go here, then you shoot up, and then you go down here. And it's not always like this either, if that makes sense. The harder thing is you don't even know where you are. You have trouble telling your neurologist what symptoms are actually happening. I don't know if I'm having a dyskinesia, this thing's moving. I don't care what you call it, but it's moving, stop it, right? That's the typical conversation that we're having. But you know that what I see or what your neurologist sees in clinic may be totally different what you guys see at home, right? How do we treat that, right? Take a video. That's what I tell my folks. Take a video. We're talking, oh, what is the common thing? We're talking about head bobbing. My head's bobbing. Is that a tremor? Is that a dyskinesia? Is that dystonia? I don't know, but first let's talk the same language, right? Let's make sure I know what you're experiencing so that I can treat it. And if I can't elicit it in clinic, if I can't elicit it when I'm with you, well, you got to sort of like wrap me into your home environment by taking a video. And you either bring it with you or you send it to your neurologist, right? On with bothersome dyskinesias. So what are dyskinesias? Are dyskinesias tremors? That's what we were talking about. You got to talk the same language. If you're not talking the same language with your neurologist, bad things happen with medicine. And you may get more dopamine when you should have gotten less dopamine, right? Or vice versa. So it's important. I'm going to sort of skip the video, but I would urge you to actually go on the internet and look at examples of dyskinesias. So the Movement Disorder Society, Parkinson's Association of the Rockies have videos that can sort of show you some examples. Michael J. Fox has frequent dyskinesias on his, interviews. When are dyskinesias bothersome? Most of the time when dyskinesias are present and they're mild, a person may not even know about them, actually. And it's hard because a family member may see them or I may see them, but the person has no idea they're going on. So it may be just this, just maybe this, okay? Maybe only action induced, so only apparent when they're really engaged or really excited about something and may not be there for the majority of the day. Is that bothersome? No, not really. Just part of the disease process. And usually a person will prefer to be a little bit more on with those early dyskinesias than to be off, if you will. And so, you know, as a care partner or as a neurologist, we'll let that happen. But when it's bothersome is when it is interfering with the ability to eat, right? Or when you're walking along and you're having your dyskinesia hitting yourself, or if your leg is very dyskinetic and you're actually falling. Those are sort of times where I'm like, no, we're done. We're going to treat this. And it's hard to treat them. Amandine is a great option. There's other options as well. I think I'm going to skip what causes dyskinesias for sake of time. Okay, the diary. I'm going to skip the complicated ones. I'm going to go to the easy one. Okay, this is the simplest motor diary. And if I take us back to the question of what is my hand doing? What is this thing that it's doing? Is it a tremor? Is it dyskinesia? I don't know. We encounter this question all the time when taking care of folks. And what I say is, great, make me a diary, please. And I'd like at least 3 of them, one for every day. Pick 3 days, I don't care. But what you're gonna do is you're gonna put the time here. Every line is an hour. I'm sorry if this doesn't come across well. But midnight, 1, 2, 3, every hour, okay? Then you're gonna write your medications. So maybe you're sleeping for all these at 7 a.m. You take your Carbidopa, levodopa. You're supposed to take it next at 12, but you forget. So you write it at 1. You write when you did it and what you took, okay? And then I wrote your target symptom. So that's this hand thing. And regardless of what it is, whenever that happens, okay, you write when it happened and how long it happened for, okay? And then activities sort of like sleep or exercise or other things that may contribute to when symptoms come about. Like, you got really great news.
Does sleep, interrupted sleep patterns or very odd sleep patterns impact how it all works together?
Yeah. Yeah, so sleep, stress, significant emotional turmoil, it's kind of like they're the tipping point for some people. You know, you always think better if you got a good night's rest. Well, you also always move better if you've gotten a good night's rest. And if you're really stressed, you can't really focus on one thing, always move better also. If your mind is clear, you've got less emotional stress. The interesting impact, we see it on really high stress jobs. So it's not to say you can't work with Parkinson's disease, but when folks are struggling with motor fluctuations and they have a high stress job, they fluctuate more and they fluctuate more wildly. And they actually look better when they stop working or when they transition their job responsibilities to something that's a little bit better. The other weird thing that we've noticed during COVID was people that exercise and encourage dopamine release of their own, their motor symptoms are better. And during COVID, when all the gyms shut down and people sort of developed a cocoon, right? Guess what? Motor symptoms were worse. Dr. Solis-Cohen, I'm so much worse. Did you stop exercising? Yes. It was crazy. Yeah. So really important to take care of yourself, get really good sleep. And often I'll see people come to me and, you know, I know my folks pretty well. They walk in, what's going on with you? Or my medicines are not working. No, there's something else. What's going on with you? What happened? And often we'll hear it. I don't know, I haven't slept for like 2 weeks. My dog died. Seriously. These are really legitimate motor impacts that we see from significant stress that you can't avoid.
Just have a quick observation.
Yeah.
As a layperson, I'm kind of thinking that like not all dyskinesias and tremors, and not all tremors are dyskinesias.
Correct.
So you as a trained eye, if the videotape it,
yes.
you would be able to.
So the more complicated diaries require that you stratify your own symptoms into on-off dyskinesia. And though that's great, I find it may be hard for a person to put themselves in a category. So I've sort of said to my folks, let's work on one symptom, right? And you bring me a video of that symptom and you just tell me when it happens. So this is a Tuesday, you'll show me the same sheet of a Wednesday and the same sheet of a Thursday, and I'll take a look at your video and I'll take a look at this and let's figure out, does this happen when your dopamine's low? Does this happen when your dopamine's high? How can I make your day even? But this is time intensive, right? And when you're in with your neurologist, like this is not always, so you got to line up your ducks in a row for them, present them the story so that they can easily come to a conclusion. But if you go in there and you're not prepared for your visit, you're saying my hand's shaking, great. Go from 1 to 2 tabs of carbidopa levodopa, right? Meanwhile, you're having a dyskinesia, and what's going to happen? Chances are you're going to be doing a whole lot worse. So communication with your doctor is really, really, really important. Speaking the same language is really important. And this is sort of as simple as I could come up with a way of documenting it for them. And yeah.
Sure, an app, and it's serious. I've had a similar situation. The app made the entry a lot more complete. The app demanded that I do something other than ignoring it and letting it go to the next one.
There are apps. I just find that unfortunately, paper and pencil for my folks is more translatable in a general sense. And so sometimes the apps, you know how people have alarm fatigue, they have app fatigues or like, I'm not gonna use that anymore. But you're right, apps are right for some people. There are apps, there's like PD motor symptom diary or something like that. If you Google PD diary, you'll come up with a few. I've seen them. But they have their own utility. I know about me, I'm able to make a quicker decision looking at it this way. And so I've sort of developed this strategy on my own.
Okay. Also, if the dementia or the short-term memory is shot, then you lose the ability to have the skills maybe for using an app.
Totally. And then also it's not always the patient who's filling this out. It may be their caregiver or their partner or their friend. Yeah. Okay, so different types of off periods. So let's say we're having our off period as our tremor, right? Off periods occur characteristically in 3 different settings. As a common occurrence before the next dose or before that dose is kicked in, okay? And this may occur 2 or 3 times during the day where you have a half an hour of a wearing off, tremor comes back or slowness comes back. Morning off period, I was saying that the dopamine properties rejuvenate. And so we don't see this characteristically for most folks, but when we see it, it's pretty profound. And morning off, it takes people a long time to get their meds going and get going. They may, read a magazine in bed while their meds are kicking in. What's bad is sudden unpredictable offs. You're canoeing and you suddenly have an off. Not good, right? You may not have access to your meds or other things. Sudden unpredictable offs don't usually happen early on in the course of this condition. They happen later, and they usually are impacted by how the gut motility occurs and where a pill may be held up. So what can we do about off time? Like, what do I think about when I see people who have off time? About all these different things, a lot of different things to think about. Can I give medicines more frequently? Perhaps lower, smaller doses, but give it a little bit more frequently. I can do that. Increase the number of doses, increase the dose itself. Extended release. Add these 2 guys, which will allow the dopamine to last longer in that synapse. Add the mimicker. Add a rescue. Let's talk about rescue. So rescue medications, there's 3 main ones right now. Avican's the oldest, it's the injection. So if you guys have ever seen an EpiPen, It's sort of like that. It's a pre-filled syringe, okay? You basically place on your leg or on your arm, and you get a dose of epomorphine, which is a mimicker, and it acts 10 to 15 to 20 minutes. Some people say, well, if I take my carbidopa, levodopa, chew it with some seltzer and a little bit of acid like orange juice or lemon, that actually is just as good as this stuff. But I also have a lot of people who find significant benefit from this in needing to turn on if they have more quick costs they need to get out of, right? They suddenly turned off in the grocery store. They need to get out of this grocery store. So they carry it in their purse and they're able to inject themselves or somebody else's. So there's a real role for it. Of course, there's an expense with it, right? A fancier medicine like that may be a little bit more expensive. Kinmobi, sublingual apomorphine. So this is like a Listerine strip, if you remember those. It's a little strip that dissolves in your mouth. You have to keep your mouth closed and not swallow for a period of time. It's a little clumsy. But
can I talk to you?
No.
Can I buy more? Oh, sorry.
So that there's a drawback there, but it has its role. And then Inbrija is an inhaled levodopa. So there's a little inhaler, but what you have to do is put a capsule in the inhaler, twist the thing to release the inhaled levodopa, and if you're off, right? So hard. If somebody's there for you, fine to do, to help you with that. But these are things that will help get you out of an off state potentially a little bit faster. Okay. Of course, as neurologists, what we try to do is avoid needing a rescue if we can before going to this, right? Rock in a hard place. So I don't know how much time we have. Are you guys going over? I'm fine with it. If anybody has to leave moving forward, there's no, okay, good. You just leave when you have to, okay? Deep brain stimulation, DUOPA, high frequency ultrasound are the three current strategies that we call advanced therapeutics. That does not mean that you have advanced Parkinson's disease. It's just that these are not like oral medications. We call them advanced. Sometimes we use them as early as 4 years into symptoms. And is that an advanced disease? No. Okay. So it's not if your doctor suggests these medicines that you're doing very poorly or you're hard off. It's just that we sometimes know what's out there and what treatment options may be working for you here. Okay. Deep brain stimulation. So deep brain stimulation, there is an electrical stimulation of those deep brain structures, either the STN, subthalamic nucleus, or GPI, lobus pallidus. I sort of pointed them out in the beginning. And what we do is we have a little sort of pacemaker device here. It has nothing to do with the heart, but it's a little battery that provides electrical stimulation. All of the wiring is under the skin, and the wire travels all the way up. There's a fix to the skull, and there's a lead that goes directly into the brain target of interest. And it provides a low voltage electrical pulse to help interrupt the abnormal motor circuit that's there. It does not make more dopamine, and it doesn't really act on generating an electrical transmission and what we were talking about earlier, neurons that talk to each other electrically, but it interrupts an abnormal circuit. And we don't understand the exact electrical nature of this yet, and we know it works, okay? It's FDA approved for tremor since '97, Parkinson's disease, as you see here, and dystonia. And there's other uses for it now outside of our domain, okay, in the movement disorder world. So DBS and Parkinson's disease, why do you get it? When should you be interested in it? The goal of DBS is to look as good as you look when your meds are working and you are in an on state without dyskinesias. So if you can think about how that feels to be on without dyskinesias and be that way all the time without the ups and downs, that's the goal of DBS, okay? If a person has additional tremor that is not improved by their medicine, that may also be helped. If there's dyskinesias there, those may also be helped. Dystonia may also be helped. Gait is a tricky one. Sometimes it's helped and sometimes it's not. That's when you really need your movement disorder neurologist to have a one-on-one with you about that in particular. And the goal is not to get rid of your medicines entirely, but you may reduce how many times you're taking meds or what the milligrams of them are, like how many different types you're taking. But generally the goal I tell people is to be much more smooth, much more consistent. It does not reverse the disease at all, okay? The DBS process is not trivial. This is elective brain surgery. Okay, this is serious. And so you have to be a good candidate. You have to know what your neurologist thinks the expectation is going to be before you go through this process, or else you're going to be upset. You have to understand the risks, right? And you have to have a really good pre-surgical evaluation, including tests of your memory and thinking with a neuropsychologist, complete evaluation with a neurosurgeon who actually puts in the hardware, okay? A movement disorder neurologist who programs the device. Beforehand, you're going to be going to clinic off medicine, take your medicine and be evaluated on your medicine so your neurologist can see the difference. The surgery happens in different ways depending on the surgeon. Okay, as time has gone on, there's been more ways than we can write on a slide. So I'm going to leave that alone for now. After surgery, and it depends on how many stages there are as to how many times you're going under general anesthesia, usually twice, okay? You would see your neurologist again for programming. The device is off until you're programmed by the neurologist, and you just get it turned on in an office like your regular neurology office. And then your neurologist follows you for reprogramming, checks your device. You may have the battery replaced, depending on which battery you have and whether or not it needs replacement when it runs out of juice, depending on what you have. That's a whole other conference and a couple hours of talking. But when is the right time for DBS? DBS we usually do 4 years of symptoms at the earliest, okay? We used to reserve it for folks who were advanced Parkinson's with gait impairment, more severe symptoms. Now we know it really helps quality of life, and we'll do it as early as 4 years, depending on if motor fluctuations are there or there are severe dyskinesias, depending on the case, okay? And it's usually right for people who are fluctuating, okay? It is not right for people who are having significant problems with swallowing, with talking, with walking. There's a little like asterisk there, like that's sort of like individual dependent. And they have to have good health because this is like at least 2 surgeries, okay? And a good support system of family and friends who can be there for them during this process. When to avoid DBS, I sort of just said it, but the other things to the other red flags are problems with memory and thinking, problems with bladder, which may indicate a Parkinson's mimic, okay? And I'm talking about incontinence, not just like many strong urges to go. Complications. So surgery has risk, right? Every time you cut the body, you can have bleeding, right? You can have infection. The risk of stroke is there. If the lead is slightly off place, it will not work as well, okay? You can be confused after surgery. There can be problems with the hardware, like these fragile wires, if there was a break in the wire, if there was an erosion of the skin afterwards. And then DBS stimulation after can cause problems with falling and speech that your neurologist may have to work around. So this is not a quick put in a surgery and everything's wonderful. But the potential for significant symptom improvement is very real. The stats about DBS, we, as movement disorder neurologists, we like to, again, be very nerdy. Everything gets a number. And they've quantified motor improvement after DBS, 30 to 50% motor improvement. It may not seem like a lot, but it's a whole lot in terms of what you see in front of you. Increased on time without dyskinesia by 4 hours a day. That's a lot, actually, in terms of quality of life. Improve overall quality of life from 17 to 50% of individuals. I don't know, it's very variable depending on what your outcome is, depending on these studies. But generally, when a person really benefits from DBS, you know, you'll hear them make some pretty strong claims about how much it's impacted. There's definitely other people who will say, my DBS was not as impactful as I thought. So I wouldn't come away with this, that like, this is the best thing since sliced bread, but if you're the appropriate candidate and you have the appropriate workup, there's potential. Okay, so DBS aside, and I'm just gonna finish through and then we'll sort of regroup for questions. Levodopa intestinal gel infusion, like I said, there's this pump that people have that you can put on a fanny pack or on a vest. The pump is connected to an infusion port that goes directly into the abdomen. So there is a hole in your belly. It allows for a continuous drip of carbidopa levodopa, bypassing the majority of the GI tract. So you're not worried about if your gut's slow, right? You're not worried about if your stomach's gonna hang onto your pills. That part is resolved. You're not worried about if you're late on your meds or if you have to dose every hour to avoid offs. This is continuous. So for some people, it's substituting all their oral medications and they're fluctuating less. Used in Europe for a long time. You guys can see 2004. Okay. Some of the nuts and bolts it requires you to refrigerate the cartridge. That is real size. So the thing is bigger than a cell phone, like that, if you can imagine, and it's sort of like an inch big. And the buttonology, or like the buttons on it, require a little bit of learning, but generally most people do just fine once they're educated on it. There's a really good nursing support system that if there are issues, the nurses will help and sort of own up to this whole system. But it requires a surgical procedure to put in the tube. So people often sort of ask me to put them side by side and say like, well, what's better? What are the sort of pros and cons here? DBS is brain surgery, right? DOPA, GI surgery, that's considered to be minor, right? You can always take the port out of the abdomen if you don't like it. Candidacy is huge here in determining who's the right person. Candidacy is not as much of an issue here. It's more, do we have the appropriate social support to take care of the tubing and the pump and make sure that this thing is hooked up appropriately? So really the patient or the care partner should be able to do that part. Social support is important at least for part of the time, and then we can autopilot through this. High frequency ultrasound, you may have heard about this. Of high frequency ultrasound, I have to sort of explain a little bit. So before DBS, there was lesional therapy. Lesional therapy, creating a lesion, creating a small intentional hole in the brain, burning a small hole in the brain, heating up a small hole in the brain, okay? That was a form of therapy that was used before DBS. What the neurosurgeons would do would be they would find that sweet spot in the brain that was causing the abnormal circuit, a part of the basal ganglia, and just create a small injury in it on purpose. We call it a lesion or injury. And then what they realized was, well, what if we just, instead of actually injuring that part of the brain, what if we just kept that little electrical probe there? And that's how DBS came about, basically. And then they just connected it to the battery. And instead of hurting the brain, injuring the brain with that lesion, electrical stimulation, here we go, okay? What this does, okay, it's non-invasive, so there's no cutting. Okay, what you do is you're in an MRI scanner, and the MRI uses the map, and you have ultrasound, very high frequency ultrasound, that's mapped in a triangulation kind of way to pinpoint the exact place we need to interfere. And by using high frequency in that manner, it creates the same effect as the lesion therapy. It effectively creates a small hole or a small area of injury in the brain on purpose, okay? So though it's non-invasive, it actually is reminiscent of an old therapy, something that was much more common in the 80s and 90s before DBS was really mainstream. And it has some limitations. You can only treat one side of the body right now. They won't let you do high frequency on both sides. So if you have tremor on both sides of the body, you're sort of stuck. You can only pick one. Now that is probably going to change in the next 10 years, but it's not changed now. Meaning that they're starting to do clinical trials on bilateral or both sides high frequency ultrasound to prove safety for folks. The concern is that cognitive impacts and gait impacts can be negatively impacted if you do that technique on both sides of the brain. So we'll see in 5 or 10 years, probably more like 10 where we are. But there's some early studies on that now that are pretty promising. The other thing is if you get a side effect from DBS, what can you do? Well, you can modulate the stimulation with a neurologist. You can turn it down. You don't go home with those side effects. That's sort of like a stimulation reduction that's done in clinic. With this, if you have numbness or weakness as part of this high frequency ultrasound, you're stuck with it. And there's no reversing it. This is not a reversible procedure. It's also not modifiable. You can't augment it. You can't say, oh, I got 30% tremor reduction. I'm gonna go back for another treatment. No, it doesn't work like that. It's like one and done. And so it's not reversible, not adjustable. And they estimate about a 15% risk of, there it's numbness, but I would also add weakness. Make sense? Yes?
Can you do, like, let's say a patient that's a high frequency focused ultrasound, and let's say it doesn't work, can they go back into DBS?
Well, it's a tough decision. I wouldn't do it on the same side. You can't do it on the same target, but the question is, can you pick one of the other targets? Yeah. It really is, that's a tough one. Okay, I did it. I'm gonna stop here. If anybody has questions, I'm not gonna talk about meds in the pipeline. We're gonna end here. So I'm happy to take any questions that you guys have.
Is there any medication besides for sleeping disorders for Parkinson's? Because my husband doesn't have any sleeping pattern. It's in 24 hours, it's anytime. And it's mostly an hour here, 2 hours there, maybe something.
There's a ton. And we sort of approach sleep pretty cautiously in Parkinson's. So the easiest thing that you can do over the counter is melatonin. In Parkinson's, we generally say you need more than the general population. So that means up to 15 milligrams of it. Beyond that, it's all prescription medicine, and they'd have to talk with their neurologist about it. Sometimes I involve sleep medicine for individuals, and they have to see a separate sleep doctor. But that pattern sounds really disruptive. And then you don't even know when to dose your levodopa medications, because when are you actually sleeping versus when are you awake? That's a tough one. Yeah.
He's a great call risk.
Oh, but yeah. Is he willing to take anything? I think is the other question.
Sometimes it depends. It's really,
yeah.
I mean, it's just whatever it feels like.
Yeah. So it sounds like there's that little tendency to be more impulsive and yeah.
Too amazing. Thank you.
My pleasure. Yeah, sleep medicines are also a risk for people who are getting up to go to the bathroom or just having erratic sleep cycles, right? Because if it doesn't totally put them out and they wake up and they try to like walk through it, they're gonna fall, right? So there's that, right? So melatonin is generally something that you can try pretty safely. Try the lower dose that you can find and sort of gradually increase to 15, but I shouldn't really even be saying that. I should ask your doctor.
He doesn't tell the neurologist.
I know
this. I tell.
Yeah.
And he puts up the front. You know, he goes and he tries to stand it straight. And when he's asked if there's a problem, he's like, no.
There's no problems. Yeah. You're not alone. It's just a hard situation to deal with, both for you and for him and for the doc. Because how does anybody help you? I know.
Spine G towers going out. Sure, everybody.
There you go.
You just staying close enough to it.
There we go.
One way or the other. Right? It's Michael.
Yep.
The majority of discussion implies that Parkinson's is primarily a result of some malfunction, if I will, between the synapses and the chemical transfer in neurons. Is there any evidence that suggests that there's also some problems in the electrical transfer between synapses of the neurons associated with Parkinson's? Because we didn't get into that. At least I didn't hear that.
It's not as well defined, and it's also it's a hard thing to explain to an audience too. So number one is it's a difficult discussion, and number two is the science is like not as strong anyway. So we present this for now.
So there's more. There's another chapter in the story.
Oh yeah, for sure. And there's multiple layers of this chapter. This is just the easiest to digest. Yeah. Yeah.
Thanks.
Thank you very much.
Okay.
Really,